So, good evening, friends. Welcome to another edition of IMA Haryana Academic Fiesta. Today, we have a joint session with the Obstetrics and Gynaecological Society of Ambala, that is SOGA. And this session is dedicated to cervical cancer prevention by HPV vaccination. This is going to be a session with expert opinion and panel discussion. And we have very learned panel with us. We have Dr. Priya Ganesh Kumar, who's MD DGO from Mumbai and DGO CPS and FICOG also. She's medical director of Sainivas Healthcare, chain of preventive oncology centers pan India. She is national convener of FOXY HPV vaccination project. She is executive member of representing India in AOFOG cervical cancer elimination program, and she is chairperson of Gynecology Oncology Committee, FOXY, from 2021 to 2024. She had been convener of FOXY GCPR Prevention and Management of Cervical Cancer 2023, and she is author of various books on colposcopy and practical gynecology, and Atlas in colposcopy and cytology. She is PhD guide for Bharati Vidyapeeth Pune and ex-HOD Preventive Oncology Department in CR Wadia, TMC. So welcome, Dr. Priya Ganesh Kumar.
Thank you, Dr. Pawan. Thank you. As Dr. Jain sir just mentioned, so thank you, Dr. Jain sir, for joining this program. And of course, IMA Haryana is doing fantastic because of Dr. Ruby Bhatia ji, who has really taken up the lead out there. And so this is a FOXY to just shed light on what this project is and how far it is scaled up. It's a FOXY IMA HPV vaccination awareness project, which is funded by ACS and CFI. So here it is a grantee name is American Cancer Society, which is the implementation partner is CFI, Cancer Foundation of India. So from FOXY and collaboration is IMA, Indian Medical Association. So now we can see why these funders and outside agencies are really focusing on India. Because we know that if the rates of cancer rates in India falls down, the globally there's going to be a difference. And because 8 out of 10 cervical cancer in India, they are found late, and we have 480 million women who are at risk for cervical cancer. It's the second leading cause of cancer deaths in women, and 1 in 53 women in India will develop this cervical cancer in their lifetime. Yesterday was the day where WHO elimination cervical cancer elimination call day. 2021 they had declared 90 70 90, and they had taken up a decade, and then they said by 2030 we would be in a position to say a world free of cervical cancer. What the 90 was for vaccination, and then 70% was for screening, and 90% was for treatment. And FOXY from there took up myself and of course Dr. Bhatia and everyone being with me in the as a member. So me being the onco committee chair, we had also taken up we had aligned ourselves, our oncology committee activities along this line. And we came up with various, and that's also the time when our phase 1 project was also sort of, coming up in and gearing up for that. So alerting the physicians and recognizing and sharing the stories and increasing HPV vaccination and cultivating vaccination physician champions. So in 2023, so in 2021, all the work started, and 2023 was a time when actually we had the phase 1 training program. It was an excellent training program. 10,800 FOXY gynecologists were trained with the master trainers like Ruby Bhatia being one of the master trainers. And it was a fantastic, and many of our Haryana FOXian friends had joined this program and had got the member, Fox HPV champion certifications. That paved way to phase 2. The phase 1 had seen lot of benefits. And if you can see this graph, even the members who were member physicians, there was a 10 plus points raise in their pre and post about the confidence level, about answering the questions, and about recommendations. That paved way for phase 2. This project, when Dr. Bhanushali took up as IMA president, and our Sunita Tandulwadkar madam took up as FOXY president. So we had a pact, we had an MOU signed. at AICOG. And from there on, the training programs we started seeing these training programs from around April, May. And so far, we have trained around 15,000. Now, this was till the October end. Now, we are on to the November end. I have to make my November, this thing correct. But this is where we land up now. But we are seeing certain beautiful knowledge shifts. Like these are the preliminary results, of course. 50,000 is where we have to touch. Yesterday, Dr. Bhanushali also was talking to all our IMA friends, the leaders, and he was insisting that let all the IMA bodies take up this program and see to it that this 50,000 is not a big this thing. If we actually every IMA branches take it up in a very this thing in a more positive note and take up these programs. So what we have found is these are the preliminary results, that the mean knowledge score has increased to 6. Then the understanding about HPV transmission, misconceptions have reduced, effectiveness, and also how to give the age dosages, that has increased. So training reduced misconceptions and consolidated the strong baseline knowledge. Talking about the beliefs and attitudes, it's actually if you believe in a subject, you would be able to impart it. So the belief knowledge has to be really there. So there has been a notable gain, substantial gain, you can see, of the belief that HPV vaccine prevents cancer. This is actually a stronger recognition of preventive potential from 86 to 96%. The most effective when given at 9 to 14 years of age, again, that has gone till 98.5. There has been a strong agreement that physicians' responsibility to recommend vaccine. That has gone to 98.5%. Now, no more we wait for the people to ask us. We ourselves, take up the onus and proactively talk about vaccines to our clients. Now, inclusion in UIP, everyone feels about it, and physician community must support the rollout. That's where the understanding is. So, training has reinforced the trust in HPV vaccine efficacy, safety, and necessity for public health rollout. And again, coming to addressing the parents' questions. So, when we have this panel discussions, we do come up with a lot of questions which we try to, figure out what answer should be we giving actually when these questions are thrown out to us. And so the ability to address parents' questions and concerns regarding HPV vaccine has improved substantially from 77.4% to 96.3%. Now, intention to recommend it proactively increased from 82% to 93.4%, and agreement on responsibility to recommend rose to near universal level. And so, beyond knowledge, the training has translated into higher confidence and intention to act, which is critical for implementation. You can see all this pre and post. And that's how the global body, the global scientific body, now this is where I presented in FIGO, it's noticed this training program has got a huge, expectation from the global scientific world. And this has been covered by UK Guardian News. NDTV had invited Dr. Nomita, myself, Sutapa Biswas from CFI. So we had an NDTV symposium at Delhi involving policymakers, stakeholders, and influencers. So what I'm seeing is it's a bright future, and IMA being the pinnacle body, this is getting a lot of sort of a positive response and a lot of this thing visibility around the scientific circle. So thank you very much, dear friends, to join today. We are the people who will be, we'll be creating an history to say that we have been seeing the first generation of the girls who have been protected from HPV and cervical cancers. So thank you for involving me. I'm there here with you all for the panel discussions as well. Thank you very, very much.
Thank you, Dr. Priya ma'am. And after the great contest setting, now we have amongst us Dr. Ruby Bhatia, who's president and life member, Society of OBG Ambala. She is vice chairperson, academic wing of North India Gynaeform. She has post MD clinical experience of 37 years with teaching experience for undergraduate students for 25 years and for postgraduate students for 23 years. She is recognized postgraduate teacher and member of Practical Obstetric Committee of FOXY 2021 to 24, member of Practical Obstetric Committee FOXY 2025 onwards also. She is member of HIV Committee FOXY 2020 to 2023 and Master Trainer for HPV Vaccination Project Phase 1, Haryana FOXY. She is National Faculty HPV Vaccination Project and she has also authored many textbook chapters in FOXY and ICOG with 94 research publications. And she had been organizing chairperson of FOGCI and ICOG CME April 2025 and annual CMB of Haryana Obstetrics Gynaecological Society in September 2024. She had many awards to her credit, and now I would request Dr. Ruby Bhatia for her presentation. Dr. Ruby, madam, please.
Thank you, sir. Thank you. It's a great honor to be part of IMA Haryana today for uplifting women health and eliminating cervical cancer. And it's a joint effort with FOGSI and IMA, and I hope we all together can do a great job. Can I share my screen?
Yeah, ma'am. It is being shared.
Okay, sir. Thank you. So, we physicians can lead the way to cervical cancer elimination through HPV vaccination in India. And our Dr. Dilip Bhanushali, National President IMA, and Dr. Sunita Tandulwadkar, National President 2025, say that HPV vaccination is a critical tool for cervical cancer elimination. And we are proud that Foxians and physicians will lead the way. So we all know that there is a very huge burden of cervical cancer across the globe, more so in India, and it is primarily caused by human papillomavirus. And we have HPV vaccination, a magic vaccination with us, a cancer vaccination. And for this, we need to communicate with the parents and we need to recommend and we need to remove the myths and hesitancies of parents and the family of the girls who are to be vaccinated.
Ruby ma'am, sorry to interrupt you. We missed the pre-survey. Can you please put on that slide?
Sorry.
Yeah, no problem, no problem.
Uh,
Yeah, very good evening once again. This is Megha Nikam, Senior Project Manager. We request you, all the participants, to kindly take this training pre-survey. You can see a QR code on the screen. Please hold on your mobile camera in front of the QR code. A survey link appears. Click on that link and complete filling the pre-survey form. Pre-survey now and post-survey at the end are mandatory part of the training to receive your certificates for this particular program. Ruby ma'am, you can go ahead. Yeah.
Okay.
Thank you, ma'am.
So we cross the globe and more so in India and developing countries, they are reading under the heavy burden of cervical cancer. Annually, 127,000 new cases of cervical cancer are added and 79,000 deaths occur because of cervical cancer in India. So this is the time to act for all of us, because if we don't act, new cases will increase to 54% by 2050. So we all together can change the picture for India. It's so sad to hear that 9 women die every hour in India from cervical cancer. And Dr. Tendros, he rightly said that the cervical cancer strikes the women in the prime of life. And these women, they are raising their children at this time, caring for their families, and contributing to the social and economic fabric of the community. So we need to act together to prevent deaths from cervical cancer. Isn't it magic that for the first time in the history, we have a vaccination which can eliminate a cancer with a joint effort? So as Dr. Priya rightly said, that we have a SDG goal 2020, where we have to achieve cervical cancer elimination. So by 2030, we have to vaccinate 90% of the girls with HPV by the age of 15 years. And 70% of all women should be screened using high performance test by the age of 35 years, and this screening should be repeated again by the age of 45. And if precancerous or cervical cancer is detected, then 90% of the women must be promptly managed. So cervical cancer prevention strategy to reach the elimination can be done with primary prevention, that is HPV vaccination in young girls before 15 years, and secondary prevention, that is by screening with high performance tests like HPV testing and pap smear testing. So these two are the pillars to achieve the cervical cancer prevention and elimination. And to achieve this, we together are the critical to meeting these targets. So it's very important for all of us to learn and to give awareness to the general public that human papilloma virus causes cervical cancer. We should know that more than 200 types of HPV viruses are there, and at least 14 types are high-risk viruses, which can cause 6 types of cancers, that is cancer of cervix, vulva, vagina, anus, oropharynx, and penis in males. So is that HPV infection occurs rarely? No, we all must know that HPV infection is very common, and 50 to 80% of general population is infected with one type of HPV during lifetime. But then it's not a very big worry. Most of these infections, they pass off themselves in 2 years, but some may persist longer and some may be caused by high risk HPV strains. So if a person has a sexual contact, or a skin to skin contact, then it can lead to HPV spread. And HPV vaccination remains the most effective method of primary prevention, which can prevent up to 98% of cervical cancer. So HPV infection, how it progresses to cervical cancer, the normal cells, they may be, whenever HPV infection persists for more than 2 years, or it is by the high risk strains, it affects the normal cells, can lead to precancerous lesion, which in the time period of 5 to 20 years may change into cervical cancer. So high risk HPV type or persistent infection which does not pass away over the time can lead to cervical cancer. So in India, 84% of the cervical cancers, they are caused by HPV high-risk strains 16 and 18. And HPV vaccination is the best way to prevent HPV infection and cervical cancer. So we must know the various facts about HPV vaccine so that we can spread the knowledge among the poorest of poor, among the healthcare professionals, so as to eliminate the cervical cancer. HPV vaccine is a prophylactic cancer-preventing vaccine and is made of recombinant L1 capsid protein, which forms virus-like particles. The vaccine is non-infectious, non-oncogenic, and produces high levels of neutralizing antibody than natural infection. Various HPV vaccines which began the bivalent for strain 16 and 18, which could prevent 84% of cervical cancer in India. Then came the quadrivalent vaccine, Gardasil 4, and now we have an Indian vaccine, CERVAVAC 4, CERVAVAC by the serum, so which can prevent not only the cervical cancer caused by 16 and 18, but also prevent genital warts, which are caused by strains 6 and 11. And there is also a nonavalent vaccine, which also covers, apart from 16 and 18, 6 and 11, high-risk strains 31, 33, 45, 52, and 58, which are responsible for the remaining 15% of cervical cancers in India. We all must reaffirm and assure all the parents that HPV vaccine is effective, it is safe, and it is licensed to start at the age of 9, so that every girl is vaccinated for HPV by her 15th birthday. And it is our recommendation which matters. So we have various scientific data which tells us that HPV vaccine is effective, as there is 88% protection against invasive cervical cancer when vaccinated before the age of 17 years. It has also been observed by a study published in 2024 after 12 years post-vaccination that observed adverse events were as low as 0.1% when the patients or the girls received single dose, 2 doses, or 3 doses of the vaccine. And this has been confirmed in a 10 years trial post-vaccination, and the results have come in 2024. HPV vaccination is absolutely safe. The WHO Global Advisory Committee on the Vaccine Safety released that it has an excellent safety profile, and it does not have any long-term adverse events. There is no greater risk of anaphylaxis, strokes, blood clots, or seizures. There is no increased risk of autoimmune disorders, no venous thromboembolism, or any demyelinating disease, and there is no evidence that it leads to primary ovarian insufficiency. The HPV vaccine, it does not affect fertility. In fact, it is safe and it may enhance fertility by preventing any precancerous cervical lesions. So, whenever we asked a question by parents or the family that yes, HPV vaccines are safe, just like any other vaccine, and millions of children have been safely received HPV vaccine across the globe. And these vaccines, they are most studied vaccines, and study shows all the recent data, long-term data shows that they are very safe. That HPV vaccination has to be started at the age of 9 years. Why we should start it at between 9 to 14 years? Because the immune response in the young children is robust, and there is increased likelihood of vaccination preventing cervical cancer and other HPV related cancers when the children are not yet exposed to these strains. And this is also the time when the children are getting other vaccination, and we can always combine the HPV vaccination with the other childhood and adolescent vaccines. The HPV vaccines have been approved, and as I've just now talked, that we have bivalent vaccine, which is only for females and covers 16 and 18 and 84% of cervical cancer. Quadrivalent vaccine, the one from Serum Institute made in India, is both for females and males, and it covers strains, high-risk strains 16, 18, and 6 and 11. The quadrivalent vaccine by MSD, Gardasil 4, is only for females in India, and it also covers strains 16, 18, 6, and 11. And Gardasil 9, it is both for males and females, and it covers, apart from these 4 strains, it covers high-risk strains 31, 33, 45, 52, and 58. So the National Advisory Group on Immunization says that 2 doses of HPV vaccination is recommended in the age group of 9 to 14 years at interval of 0 to 6 months. The reduced dose schedule of HPV vaccine, that is single dose, still awaits Drug Controller General of India approval, and vaccinated girls, which we must also advise and send the message to the public that all girls who are vaccinated, they also must follow cervical screening guidelines in the adulthood. So there are various recommendations by FOGSI and other societies. As of now, 2 doses between 9 to 14 years, 6 months apart, 3 doses above 15 to years, that is between 15 to 26 years, 0, 1, 2 months and 6 months apart, and 3 doses for older women till 45 years. Then some countries, we may give 1 dose instead of 2 doses between 9 to 14 years and 15 to 20 years, but it is off-label and still awaits DCCI approval in India. HPV vaccination of girls can shift the global landscape. As of now, the 145 countries have started HPV vaccination in their national immunization program. 64 countries are giving off-label 1-dose HPV vaccination till January 2025. And 71 countries, they are giving to females only, and 76 countries are giving this HPV vaccination to both boys and girls. And what matters here is effective communication with the parents and the family. And this is our recommendation which matters. So why our recommendation matters? Because parents, they always consider healthcare professional as the most credible source of information on HPV vaccination. They consider the doctor after God, and they trust the doctor like a God, and because they feel that it is a doctor that heals the patient. So HPV vaccination need to be recommended by all the healthcare professionals. And at the same time, we have to clear the myths and the questions and the hesitancy which the parents have, so that parents respond and get vaccination to the young girls between 9 to 14 years. And we should always try to make a positive recommendation. If there is a question, whenever some parents come, maybe for some other reason, we should always ask about their daughters or granddaughters as per their age. We should note child's age, and we should always tell them, parents, that girls of this age are due for a vaccine that prevents the cervical cancer. And we should recommend this vaccine, that they should vaccinate their daughter or granddaughter. Most parents, they will not come in seeking an HPV vaccine advice from us. So we doctors, we always have to find opportunities to proactively recommend the HPV vaccine to the parents of 9 to 14-year-old young girls as and when we get this opportunity. So parents, they can ask questions. So we should always advise that they should vaccinate the girls younger, because we will prevent the most HPV cancers at that age. And this is a HPV cancer preventing vaccine. So we should always project HPV vaccine as cancer preventing vaccine, and we should strongly recommend that they get their daughters or granddaughters vaccinated. So the common questions which parents can ask: does HPV vaccination work? So we should always say it will work. It works very well. And the various scientific data, it tells that HPV vaccination is effective at preventing cervical and other HPV related cancers, that is vulval, vaginal cancer, oropharyngeal cancer, anal cancer, and penile cancer in boys also. So, and HPV vaccination can prevent most cervical cancers. Another question can be, does HPV vaccine has side effects? We should emphasize that it is a safe vaccine with no long-term side effects. And yes, the child can have minor side effects as with the other vaccination, like redness at the site or low-grade fever, or rarely the child can have an allergic reaction. So, and rarely they can have fainting also. So we always keep the child seated for 10 to 15 minutes after giving the vaccination. Then another question, will the HPV vaccination harm my daughter's fertility? So the answer should be no. It does not affect or deteriorate fertility by any means. Rather, it protects any precancerous cervical lesions and it may improve the fertility. So, all parents, they will have a hesitancy and they will always ask why the daughter cannot be vaccinated after marriage. We have to emphasize that HPV vaccination is recommended for all young girls between 9 to 14 years because at this time the exposure to HPV is minimal, so the protection against cervical cancer will be maximum if she is vaccinated before 14 years. So that should be a birthday gift before 15th birthday to every young girl from parents to get vaccinated. Then another question, is there a cost to the vaccine? Yes, as of now in India, the different vaccines have different costs, but there are proposals that government will bring it into the immunization program by 2026. But then we also have to emphasize that the cost for preventing cervical cancer or cost for vaccination is much lower to the cost of treating a cervical cancer. So that is the way when we can recommend and counsel the parents. Then another question, that can boys get the HPV vaccine? Yes, the HPV vaccine can be given to both boys and girls, as boys will also be prevented for any oropharyngeal cancers, anal cancers, and penile cancer. But as of now, our focus is to prevent cervical cancer deaths so that no young girl in the after 2030 hears that she has cervical cancer. So doctors, we all, healthcare professionals, we are critical to cervical cancer elimination because we are the most trusted source for HPV vaccination and information to the parents. And increasing HPV vaccination coverage in girls will avert more deaths per person vaccinated than any other immunization activity. And over 80% of cervical cancers can be prevented through HPV vaccination, and this is the way to eliminate cervical cancer in India. So the focus today is putting the pieces together in India. India's first HPV vaccine is already launched and it awaits inclusion into the national immunization program. And we need to catch up with the Ministry of Health Family Welfare campaign, and it is strong physicians' recommendation which can pave way to the maximum HPV vaccination of the young girls of more than 90% by 2030. So today we all have shared that HPV infection is very common and more than 80% are affected by this in their lifetime. HPV can cause 6 types of cancers: cervical cancers, vulval cancer, vaginal cancer, oropharyngeal cancer, anal cancer, and penile cancer. For this, we have a cancer-preventing vaccine, which is safe, which is effective, and it is we all who recommend it and who counsel the parents. But the sad part or unfortunate part is that not enough young girls are still being protected with this vaccine. So we all recommend the HPV vaccine to all 9 to 14-year-old young girls in our practice. So we have various resources available in all languages. And now is the time for a post survey. All of you, please click on this QR code, or you can go to the chat box and join the link and put this post survey. And then we will go to the panel and the questions.
So, Sunila ma'am, should we start the panel discussion?
Yes, I think we can start the panel discussion now. Okay, so now we move on to the panel discussion. And this is a reverse panel actually, where the questions will be asked by the panelists and answering the questions will be our experts, Dr. Ruby Bhatia, who has already been introduced, and Dr. Priya Ganesh Kumar. And we are very honored to have both of you in this webinar, and we hope to gain by your expertise. And the third expert in the panel today is Dr. Preeti Garg, who is an associate professor in the Department of Oral Medicine and Radiology at Mulana Dental College, sorry. And now I will introduce the panelists one by one. The first is Dr. Gurnita Kaur Bhalla, who's a senior consultant, Well Women and Menopause Clinic at Faridabad. She's also the chairperson of Aao Gaon Chalo project, IMA Faridabad. The second panelist is Dr. Praveen Sharma, who is the professor and head of the oral surgery, oral and maxillofacial surgery department at DAV Dental College, Yamunanagar. The third panelist is Dr. Ritu Maggo, who is a senior gynecologist and past president of the Yamunanagar Obstetrics and Gynaecological Society of Yamunanagar. And the fourth panelist is Dr. Anupam Garg. She's from Kethal. She's a consultant in the Garg Eye and Maternity Hospital, Kethal. And finally, we have Dr. Gunjan Goyal, who is a senior family physician based at Rewari. She's the director of City Heart Clinic and Medical Center, Rewari. And she's also the chairperson of Gulabi Punk and WDW IMA Rewari, with a special interest in preventive medicine and elderly care. So the opening batswoman, I should say rather, is Dr. Gurnita Kaur Bhalla. Ma'am, please ask your questions. Dr. Gurnita Kaur Bhalla, please.
Good evening to all. Thank you, Jain sir, Pawan, Goyal sir, Sunila ma'am, Ruby ma'am, and the entire team of Ambala for making me a part of this CME. Moving on to the first question for our expert panelists. Ma'am, like if a couple is using condoms, then isn't the condom good enough to protect against HPV infection?
So to answer your question, this is actually a very common question which has been asked time and again. The understanding about an HPV is now this virus doesn't even require a penetrative sex, okay? This is a skin to skin contact. So having an intimate contact also is enough for the transmission. Now, one thing which I would like to stress over here regarding HPV is this HPV is very common in our country, you know. Out of 5, 4 will have an HPV, but every HPV doesn't mean a cancer, and every HPV doesn't mean, you know, promiscuity behavior. So this is something which we have to remove it out. So condom is going to cover a little bit part of it, but the whole skin or the whole thing is not covered. Hence, definitely condoms has a role to prevent all the STIs and other pregnancies and all that. But when you talk about HPV, this is not a sufficient one. Yeah.
Thank you, ma'am, for such a nice explanation for this, because this is a common question which is asked when we are telling the people. Then the next question is, ma'am, that even after vaccination, we are needing the pap smear test and other tests for the cancer screening. So, what is the need for the vaccine then at all?
Yeah, again, a very, very common question. Now, let's understand the vaccines are covering up 16, 18. Okay, when you talk about the quadrivalent. And there are 14 HRHPVs, basically, 150 strains. But out of that, you've got a low risk strains, you've got high risk strains. So, high risk strains have got, don't say 14, this thing. So now, whenever we are talking about, we have been covering this also, that when we were giving bivalent vaccine, people used to ask, why not quadrivalent, why bivalent, and all that stuff. Even if you understand phylogenetic resemblance of, say, 16 to 31 and 18 to 33 and 45, that means invariably somewhere by giving a vaccine of quadrivalent, we have covered almost a bivalent and quadrivalent, we have covered the 4 strains 16, 18, 31, 33, 45. Okay, nonavalent, you would have covered up 52 and 58 also. What about the rest of the strains? Even though they are causative factor for, say, might be 0.3 to 0.5% of the cervical cancers, where 16 and 18 plays a major role, following that is 31, 45. following the major role for getting cervical cancers. So what about then those strains which are going untapped? And that is the reason we tell this to our clientels and the patients that even though you are taking a vaccine, you are definitely protected by the major strains. But what about the rest of the strains? And hence, having a screening, and that too pap smear screening, I would go one step ahead because WHO talks about screening with a high sensitive test with a very good negative predictive value. That is an HPV test. So if you're doing an HPV test every 5 yearly and you've taken an HPV vaccine, but still you will have to get your thing tested by PAP then every 3 yearly or with HPV every 5 years.
That means, ma'am, these two things are complementing each other so that we can reach our goal. Like
Only
the
then we can reach cervical cancer elimination.
And
yes.
nowadays,
These are
what
the
we are
pillars.
seeing is, sorry to interrupt, but just going through that, I remember that nowadays the strain which we are seeing in the country post vaccination, whatever we haven't gone till that UIP level of this thing, coverage, but still, with many of the studies we are seeing, HPV strain 31 is on rise, 56 is on rise, and 68, which is a probable carcinogen. Now that's also on rise. Hence, definitely these tests are important.
Thank you, ma'am. And ma'am, as we've already covered, which are the high-risk HPV genotypes which we are seeing?
So the various high-risk HPV genotypes, as ma'am has told us, 16, 18, they are, but 31, 33, 35, 39, then strain 45, 51, 52, 56, and 58, 59, and 66 and 68, as ma'am has rightly said.
Yes.
So with the vaccine, we also need to do screening so that if it is this cancer is because of the strain which is not covered by a vaccine, we can detect it early in precancerous stage and prevent any cancer, HPV related cancer. Survival.
Okay, thank you, ma'am. And you have already said the cancers, which cancers are attributed to HPV infection. So all the 6 cancers you have already told about the cancers which are attributed to HPV
Giving
infection.
on HPV related cancers, I will take you through one PPT. If I'm able to share it, it will be of a great advantage for people. Um, you can see this slide which I showed to you all. This actually makes us understand this subject well. Yep. Can you see this slide? So
Yes,
now
ma'am.
HPV related
Yes,
cancer
ma'am.
Yes,
globally.
yes.
You can see.
Yes, ma'am.
Now, oral pharyngeal cancer, HPV is contributing to 13 to 56%. Anal cancer, 88%. Penile cancer, 50%. Vulvar cancer, 43%. Vaginal cancer, 70%. And cervical cancer, 100%. But, and again throwing light on what is the Indian statistics covering about this. So 660 million cases of HPV related diseases are reported globally. Out for cervical cancer, we are contributing 20.5%. For vulvar cancer, 7.6%. Anal cancer, India is contributing to 10.7%. Vaginal cancer, 30.8%. Penile cancer, 29.6%. And oropharyngeal cancer, 20.9%. And when we talk about WHO 90, 70, 90, only one slide I want to bring to your notice. It's going to be an eye-opener slide. You know what is our actual Indian scenario for 90%, what we are talking so much of vaccination, is only 0.01%. And for screening is only 3%, and for treatment is just 10%. So this is exactly where we are today.
We need to bug up. We need to really,
Buck up.
really fix it. Yes, ma'am. We need to, and so we need to have more of these sessions so that more people can get educated and counsel our patients.
Correct.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Gurnita. And now moving on to oral health in HPV infections. And for this, our expert is Dr. Preeti from Mulana. And asking her questions will be Dr. Praveen Sharma from Yamunanagar. So, Dr. Praveen, I request you to go ahead with your questions addressed to Dr. Preeti.
Good evening, everyone.
Good evening, ma'am.
My first question is, how can the oral cavity serve as an early warning site for systemic HPV infection?
Good evening, everyone. Ma'am has asked me a very important question. Like we all know that oral cavity is a mirror of body.
Yes.
Any disease in the body, it first manifests in the oral cavity. So oral cavity is readily accessible, highly vascular, and immunological active mucosal surface, in which HPV related changes appear in the earlier stages. First of all, there are early detectable mucosal lesions like benign lesions like papillomas, then condylomas, then Hex disease, which is hyperplasia of epithelium. Then there may be non-resolving erythroplakia or leukoplakia. Then there is squamous cell carcinoma. These are all detectable with the naked eye. So when we see the oral cavity, we can early diagnose, and if we see the benign stages, we can tame it there. The second thing is early biomarkers present in the saliva, like HPV DNA, HPV messenger RNA, then immunological markers like cytokines increase, IgA increases. Then there will be change in the microflora of oral cavity, which will lead to more of the opportunistic infections. Like there is no reason, but there is candidiasis, persistent candidiasis, or you will find that a person is coming with the latent viral diseases which have become active, like Epstein-Barr virus diseases or herpes simplex diseases. Then, ma'am, the sites where HPV harbor, like oropharynx or base of the tongue, we should see these places because there the mechanical action of saliva is very less, and there is more chances of biofilm production, which again harbors HPV more. Like oropharynx, it has the mucosa which resembles cervical mucosa of the female. It has a transformational zone of epithelium. So same is with tonsillar crypts. Now the last part is that oral mucosa serves as mirror of systemic viral activity. Why? Because it has rich lymphoid tissue. We have adenoids, we have tonsils, we have Wardier's ring, and these are the most active lymphoid tissues which react to the viral infections in the body. So if we are very meticulous, seeing the oral cavity, we can say that there may be some viral systemic disease going on.
True. Okay. So if I'm seeing a lesion like leukoplakia or erythroplakia in the oral cavity, should the patient be also seen by a gynecologist, or should the patient?
Yes, ma'am. Yes.
Yes. Okay.
Definitely, madam. If a male comes with, in whom erythroplakia and leukoplakia is not getting cured by any of the treatment or leaving the habits, then you should get the female in the house checked for HPV infection, because it is very common nowadays that orogenital transmission is occurring. We had a case in our college itself.
Okay.
A male came with oropharyngeal cancer, and he was non-smoker, no tobacco chewing, nothing at all. And he had grade 2 oropharyngeal cancer due to HPV 16. Then his wife was checked for cervical growths, and there were condylomas present there.
Okay.
Dr. Preeti, here I would want to ask, I was always keen on asking a dentist, and I'm very happy that you have come over here with the so much of abundance of knowledge in this subject. So I wanted to ask a oral expert, that how do you all take the swab from the oropharynx for HPV test?
Ma'am,
And what method do you use?
Ma'am, we have brushes. Actually, the brushes are the ideal way of collection. Otherwise, what we do is we are doing कि हम ना saline लेते हैं, normal saline, 10 ml to 20 ml. We tell the patient to rinse the mouth nicely, and we then take it in a container. उससे क्या होता है मैडम, ओरोफेरिंग्स भी कवर होता है. बट इफ वी टेक अ स्वाब, then it is a bit difficult to go to the oropharyngeal level.
नहीं, आप फिर वो जो गार्गल करके या whatever नो रिंस करके you put it up into the saline, do you put it into that ethanol base जो हम normally HPV टेस्ट के लिए जो लेते हैं ना, liquid based cytology?
Yes मैम, मैम लेते हैं, करते हैं मैम, करते हैं. स्वाब्स को तो रखते ही 80% इथेनॉल में at -80 डिग्री सेल्सियस है. बट सलाइवा सैंपल ऑल्सो बिकॉज दैट्स जो सलाइन हमने नॉर्मल लिया है, we don't need to put ethanol in it because it has saliva and it is already, and we send it for PCR, basically polymerase chain reaction. Nested polymerase chain reaction is the best. Yes ma'am. But
so
if we are collecting with cytobrush,
which all strains do you look out for? जैसे हम सर्वाइकल करते हैं वैसे ही आप देखते हैं सारे वो 14 strains देख लेते हो क्या? क्या से देखते हो? I mean, what all you see?
हाँ जी मैडम, हम 14 नहीं, मतलब usually 16 and 18 are found in oral cancers. 16 and 18
और
are
आपके
found.
हिसाब से कितने लोगों को अभी तक तो आप कैसे करते हो? You all do it on a routine basis और जब suspicion होता है तो करते हैं?
मैडम वही प्रॉब्लम है, दैट्स व्हाई आई हैव एंटर्ड दिस सेशन, बिकॉज हमें करना चाहिए एनी काइंड ऑफ these regions. If we come across, we should check for HPV virus. We are not doing it actually.
It's very good learning that whenever we find persistent oral infection, as ma'am has in a man, we must examine the wife, and if we see and all women we are testing for HPV and we find high risk, we must examine the oral cavity.
आजकल ये oral sex and everything, the altered sex behavioral patterns are increasing.
Yes ma'am, that's why it has increased actually.
हाँ, और मैं तो ये भी देख रही हूँ anal cancers are increasing. Like I am a teacher for colposcopy. हम लोग कभी एनोस्कोपी वगैरह सिखाते हैं. And we are seeing these anal lesions also coming up, precancerous lesions also coming up. तो ये oral वाला जो चक्कर है ये हमें ज्यादा समझता नहीं है as a gynecologist. So we always find out oral experts और उन्हीं को भेजते रहते हैं. So what will be your take home message? And I really want to know from you for all the people who have joined here.
Ma'am, if a female comes with an HPV infection, you have seen, or a female has come with a checkup for you, you should check the oral cavity also for papillomas even. It does not matter. You get the papilloma removed, laser surgery, get it checked if it's HPV positive or not. So everyone should be checked for oral lesions. Oral lesions, primarily benign lesions, come very early in the mouth.
तो आपके पास क्या कॉल्पोस, हमारे जैसे पास कॉल्पोस्कोप है? Do you have anything of that sort to even check out precancerous conditions in the oral cavity?
Sorry, ma'am.
Do you have any tool which actually has a magnification and to check on to any precancerous conditions? Because HPV usually gives precancerous conditions, right?
Yes,
like how we have it in our cervix.
Hanji, ma'am. But what we do is we send it for the biopsy. We will remove the whole thing. Papillomas are very easy to be removed. Or as a matter of fact, condylomas also, hyperplasias, or everything we remove.
तो मेरा ये पूछना है आपसे कि ओरल कैंसर के पहले क्या कोई प्री मैलिग्नेंट कंडीशंस
है? मैम होता है, अगर आप सलाइवा टेस्ट करें, सलाइवा, यू टेस्ट द सलाइवा फॉर HPV DNA, HPV mRNA. It will come very early in the saliva. These are two biomarkers. You will find them even before the growths.
Thank you.
And it is very easy test, madam. It is patient is very comfortable with the tests.
The cost remains a factor.
Yeah.
You just have to cytological brush is very small brush.
नहीं, ब्रश का तो खैर इजी है. आई मीन एंड एज यू सेड दैट रिंस करके आप वो सलाइवा को ले लेना. So that's again a very great take home message for all of us.
Yes, ma'am. It is very easy, ma'am.
बिल्कुल. Thank you.
Thank you so much.
Thank you, ma'am.
I have another question, ma'am. Why are HPV positive oropharyngeal cancers are common in men, while HPV related cervical cancers are more common in women?
Ma'am, basically it reflects both anatomically and behavioral differences in males and females. ठीक है. First is biological susceptibility. What is biological susceptibility? अभी क्या है, HPV जो होता है ना मैम, वो epithelial basal cells में होता है. And if we'll see in males, जो alpha-6 integrin receptor है, which causes the stem cells to multiply in these basal cell layers, they are more. तो अगर HPV इसमें चला गया तो वो इस इंटेग्रिन के साथ जुड़ जाएगा and there will be more of multiplication. And this factor, that means alpha-6 integrin, is less in females actually. So this is biological susceptibility. इसलिए oral cancer females में कम होता है. Second is sexual behavior. Ma'am, females usually multiple partners lesser, है ना? And the males, they have more likely to have higher number of oral sex partners. So there are more chances of orogenital transmission. The second thing is this. Third is immune response. In males, the immune clearance is less as compared to females. अगर आप females का saliva test करेंगे तो उसमें IgA और cytokines ज्यादा होते हैं वैसे males से. तो इसलिए oral cancer females में कम होता है. And moreover, जो estrogen और progesterone होता है females में, वो epithelial turnover बढ़ाता है. तो मुंह में एपिथेलियल टर्नओवर जब बढ़ जाता है तो ओरल कैंसर फीमेल्स में कम होता है as compared to males. Then males have more of tobacco and alcohol habit. That is again a co-factor because
High risk.
there is more harboring of HPV. फिर मैडम जो वैक्सीनेशन हमने शुरू की मेल्स की नहीं, अभी रूबी मैम हैज सेड दैट वी आर मोर प्रमोटिंग सर्वाइकल कैंसर लाइक प्रोटेक्शन. तो मेल्स को हम दे नहीं रहे हैं, मतलब वी आर नॉट लाइक दैट, वी डोंट गिव इट टू मेल्स.
अभी कैसे ना जेंडर न्यूट्रल वैक्सीनेशंस आ रही हैं व्हिच इज रियली नाउ कैचिंग अप द वोग.
हाँ, तो अभी तक इसलिए मैम मेल्स में ज्यादा होता है एंड सर्वाइकल फीमेल्स में इसलिए होता है बिकॉज द सर्विस का जो एनाटॉमिकली ट्रांसफॉर्मेशनल एपिथेलियम है, इट हार्बर्स मोर ऑफ एचपीवी. अब जहां पे इतना हार्बर हो गया और माइक्रोब्रेशन हुआ आपका थोड़ा सा भी, इट विल एक्टिवेट. द सेकेंड थिंग अगेन इज ईस्ट्रोजन एंड प्रोजेस्टेरोन. वो मुंह में तो बचा रहा है पर नीचे जब आई मीन लाइक इन सर्विक्स व्हेन इट इज गिविंग मोर ऑफ टर्नओवर, तो वो क्या कर रहा है, वो माइक्रो एनवायरमेंट दे रहा है एचपीवी को फॉर परसिस्टेंस एंड प्रोग्रेशन देयर. एंड थर्डली अर्लियर सेक्सुअल एक्टिविटीज आजकल बहुत हो गई हैं एंड मल्टीपल
So, oral cancer risk factors are more in males, natural susceptibility for oral cancer more in males, and
Madam, may I come in here? I think we had already started vaccinating male also.
Yes.
We are vaccinating all the boys from 9 years onwards.
Understood is having a smoking. I mean, if you see, but हालांकि आजकल smoking has become in gender neutral. But we do see this type of risk behavior, तंबाकू, गुटखा, पान, खैनी, and all that thing also leading more to.
Yes, is a very great. Yes, definitely.
That's a very important risk factor.
It is a co-factor, ma'am. It drives the mucosa, and so there are more of chances like saliva clearance becomes less.
Correct. Clearance becomes less. Yes.
Less, ma'am.
So we must examine the oral cavity also.
Yes, ma'am. Every patient.
Yeah.
So, Dr. Parveen, I think you are through
I
with
can
your
proceed.
questions.
Yes, I
Yeah,
have
you can
another
proceed.
question.
Yeah, yeah.
Can oral HPV infection serve as a marker for genital HPV infection?
Yes, to some extent, but we cannot rely on it, ma'am, totally. Because there are studies which say that there is correlation between oral and genital HPV infections, especially in the high risk ones, like 16 and 18 genotype. Because 16, 18, it is present genitally, it may be present orally, but it is not reliable. But we have seen studies say that cervical HPV infection in women, if it is present, then the female will have threefold higher risk of having oral HPV infection. Maybe benign, but there will be that. But it is not a reliable test. But dentists should consider recommending gynecological evaluation when persistent oral HPV lesions are there in high risk patients, in children, and in immunocompromised persons.
Okay, ma'am. And last, what should a gynecologist look for when inspecting patient's mouth during examination of a HPV positive woman patient?
Ma'am, all the classical mucosal manifestations, and these are visible in a very simple intraoral inspection, routine inspection. You need not have anything. You tell the patient, open your mouth. You will see some growths like papillomas. They are finger-like projections. They may have peduncle or they may be sessile growths, painless growths. Then there might be condylomas, which are again pink colors, plaques or papules over the oral mucosa. Then there may be this vulgaris, verruca vulgaris. ये क्या होते हैं? Keratinized warts होते हैं, मैम. ठीक है, काफी देर से पेशेंट के मुंह में है. If you see it, you just get it, cryotherapy करो या laser therapy and give for biopsy. And then you can see for ulcerative lesions which are non-healing, or you can see for erythroplakia or leukoplakia again which are non-healing. Then you see for sore throat. A patient female comes to you and she says, I have a sore throat and it is chronic. Almost 28 days of the month I am having some feeling in my throat, So you should always get her checked by ENT person. Maybe some Waldeyer's ring or adenoids or tonsils may be enlarged. Then is dysphagia. The same reason again. If there is some oropharyngeal involvement, dysphagia will be there. And chronic hoarseness. This is very important, madam. A female comes to you and she has heaviness in her voice. Only reason somewhere is oropharynx involvement. So for early detection of oropharyngeal lesions in HPV positive women, we should refer such cases to dental or ENT specialists to prevent the progression to malignancy. All these classic features, ma'am, these are seen by naked eye. And you will be very sure, you will come to know that these may be due to HPV presence.
Ma'am, routinely when we are seeing such lesions like papillomas, leukoplakia, erythroplakia, and they are existing for say more than 15 days, 20 days, and kind of we label them as non-healing, we pick up a biopsy and send it.
Yes, ma'am.
Okay.
Ma'am,
so,
but
okay.
15 days is not a big time for leukoplakia kind. Erythroplakia, I understand.
If it
but
is a mixed
leukoplakia
white
will,
and red lesion, then we don't wait for more than a month. Then we immediately, because we start suspecting. Exactly. So is biopsy enough?
So you send a biopsy for that, or you take a... Ma'am, take it with cytotoxic brush and send it for PCR. You will come to know whether it is due to HPV or some other.
Okay, so along with
but
biopsy,
it should be
we
done.
should do
HPV
the brush technique also.
Brush is very important, madam. It is chair side investigation. does not harm the patient, and it gives us more good results.
Okay, all right.
Okay. Thank you, Doctor.
Thank you.
I'm sorry, ma'am. I never wanted to use those words. I don't know why I did it. I'm sorry.
It's all right. Thank you, Dr. Preeti and Dr. Praveen. And I think the dental part of it has taken up very well. And it was a great learning for all of us as well. Thank you. And
Thank
now
you so
moving
much.
on to the next panelist, I request Dr. Ritu Maggu, ma'am, to ask her questions.
Good evening, everyone. Do we
Good evening.
see in the near future any screening test which would serve as a bridge between the gynecologist and the dental surgeons in HPV management?
See, there are good tests coming up, like, P16, Ki67. These are your surrogate markers which comes up. And I feel these type of, what is the understanding then it gives is the integrated HPV. And it also gives us an understanding, it's INK4A, that is inhibitory kinase, kinase inhibitors and all that. This, I think, if we can pick up, and these are actually done by cytology, it has also been done by histopathology. Now, what does that make us understand is it makes us understand that yes, this virus has become now integrated and your mRNA is active and P16, the 16 and no, 6E6 and E7 proteins are now on the rise. Now, whenever there is an E6 and E7 proteins which are on the rise, definitely I'm very, I don't know, I've not done a research onto this or not entered into the domain of, going into, some research analysis. But according to the science which an HPV progresses, if ever there is an E6, E7, which is picked up either in 2015, I was doing mRNA tests, which was available in the market. Those days, it was a research-based molecule. And because me being a researcher, we were using this for, understanding integrated HPVs. Then that didn't come up into the actual, array. Now, I think Aptima is bringing this E6, E7. But otherwise, inhibitory kinases, and they are cellular activities. If the inhibitory kinases are really affected, your P53 is affected, your RB is getting, phosphorylated. So what's going to be there is going to be an on cycle, right? It's going to be a mitose. It is an on cycle. If there is an on cycle, there is no apoptosis, there is no senescence. If these things are understood, I think by chance of low immunity and no low propensity, even the cervical part, the throat and mouth and throat, and if there is some smoking or gutka and all those things also coming up, oral sex, these things are also coming up. Now, respiratory papillomatosis, there's been increased RRP, recurrent respiratory papillomatosis. We are seeing this in the third decade of life. So all these things are correlations are definitely there. You can't see a human body as cervix as a separate part, anus as a separate part, or your mouth and oropharynx as a separate part. No, it's a human body. So wherever we are going to have this, there is definitely going to be a connection. And I think your question is extremely good, Dr. Ritu, because this opens up a window for research, which can be a combined research by gynecologists and, oral experts. Thank you.
So, what is the burden of HPV related cancers in India? It overall has been discussed, but specifically in India,
it's quite high.
It's very, very high. In fact, we have just now talked that of the total, 1/5 of the cervical cancers are in India only annually.
And HPV related cancers, orally,
and all
basically.
HPV related cancers, they are also almost 1/5. Madam had told us that vulval cancers, 7.8%, they are in India. Anal cancers, 10.7% are in India. And vaginal cancer burden is 1/3, 30.8%. They are occurring in India annually. And penile cancer, again, 30%, 29.8%. And oropharynx also, India's burden is 20.9% of the global burden. So we are under a huge burden of HPV cancers. And it is high time first we Vaccinate our young girls, followed by all young boys also.
So, ma'am, what do we understand by WHO's call for the elimination of cervical cancer?
Yes, this is
It's a very the understanding is quite simple. I would take you through this slide. Just check on this slide and check on if we have this implemented in our country, how are we going to progress? So, here we are. Now, this is understanding is WHO goal, okay, 90, 70, 90. That is 90% of girls being fully vaccinated. What do you mean by fully vaccinated? Optimal doses. And by the age of 15 years. Here, and then 70% of the population, I mean, eligible population for screening, getting screened. Now, when WHO talks about, it also talks about LMIC countries where it is a regular screening might be a little challenge because of so many demographic conditions. So it is saying that with a high performance test, that is an HPV test, high performance test is a test which is the most eligible test for screening with a very high sensitivity. That means it will pick up all the possible positives. It can be true positives as well as false positives. All the possible positives are picked up with a test, and that's your HPV test. And it has got a very high negative predictive value. That is, if you say a person is HPV is negative, she can be really relaxed for a bit of, say, 5 to 10 years. So having these type of tests at least twice in a lifetime, 35 and 45 years, and then 90% of those who have been diagnosed as cancers and pre-cancers being treated. Okay, now if this 90, 70, 90 thing is implemented in our country, how are we going to fare up? This is our understanding. We have to now talk about our country. WHO has set this goal that, okay, by 2030, we will have a world free of cervical cancer. That means what? Less than 4 cases of HPV-related cancers per 100,000 women years. Or cervical cancer, 100,000 women years. Now, what is our current scenario? Let's go through that. Now, this is a slide which is showing current vaccinations in a screen. Nowhere coming down. But look at this. If you have an intensive vaccination starting from this 2020, only intensive vaccination, I'm not talking of screening as of now. You can see that we can reach less than 4 per 1 lakh by 2120. But if you put up intensive screening along with vaccination together, so you can see this reduction of less than 4 per 1 lakh by around 2070. All right. And if these 3 pillars of elimination are being actually put up, in India, we can avert 1 lakh deaths due to cervical cancer over the next decade and 10 million deaths over next century. So this is exactly how to understand 90, 70, 90 for our country.
And ma'am, what according to you, should we do to improve the HPV vaccine intake?
The best thing is have a conviction.
Counseling is also very important.
Before counseling, Dr. Ruby, I would put up as conviction. Have your own conviction. Now, whenever you sit in front of the patient and you have little doubts on your own, your face itself shows.
Yeah.
A patient asks, a lady asks, comes and asks, and then you say, हाँ ले सकते हैं. वो अगर पूछ रहे हैं, मैडम ऐसे एक वैक्सीन आई है, और हम कहते हैं, हाँ भाई आई है, ले लो, दिलवा दो, लगवा लो. Against that, भाई आपको पता नहीं था, ये तो लगाना ही है, जरूरी है, बिल्कुल जरूरी है. This is the conviction. To have that.
And ma'am, if there is a disruption in the vaccine dosage, say due to pregnancy or something, then what do we do? What is the recommendation in that case?
She can take it after delivery. As and when she delivers, she can take the next dose of the vaccine.
Suppose she's taken 2
answers. Can we be brief on the answers because it is already
yes.
And we can sum up the panel.
Right, sir.
Yes.
Yes.
Dr. Ritu, ask the next question, please.
I finished with my questions.
Yeah. All right. So now I request the next panelist, Dr. Anupam Garg from Kethal, to ask her questions, please.
Yeah. Good evening, everyone. It's really good presentation. Thank you so much being myself a part of it. My question is there a need for family-focused education regarding HPV?
Yes, that is
Absolutely.
very important, madam, because 9 out of 10 vaccine takers, the decision to take vaccine is not taken by the girl or the person who wants the vaccine. It is the family who takes the decision. And in fact, I would say it's not on the first counseling that they will accept it. They will always say, no, no. But when you keep on doing that, they will become positive and they will receive it.
Yeah.
So family counseling and awareness about vaccination to the family is very, very important.
Otherwise, ma'am, it's the age group 9 to 14. No, the girl cannot take decision herself. Yeah. The,
Otherwise, also, even in the reproductive, those who want after
yeah,
40,
later on.
or even
Till
if they are married till 45 years, they would always like to discuss it in family. Maybe because of financial issues or for having hesitancy about the side effects. So it has to be the family which has to be counseled well.
Yeah, thank you.
Yes, ma'am.
My next question is, ma'am, what is the role of healthcare professionals in overcoming vaccine hesitancies?
Counseling, conviction, and clear-cut understanding.
So they remain the important pillars to for the families, so that the young girls, they accept the vaccine for their young daughters and young granddaughters. And we
And
should
be
fight
proactive. I have understood one thing in my whole career, and what I've seen is, if you jot down as a healthcare provider, you're taking the notes, right? वहां पे ना लिखिएगा advice vaccination, advice screening, even though if they are not taken, but then that keeps on hitting on them. And also take the history. If not vaccinated, put it down. HPV vaccination not taken, HPV screening not done. So ये जो है ना, ये जब reiterate होता रहता है and it comes up into your own pen, you will see how our own behavior changes towards our history taking.
Yeah, counseling also. Yeah,
yes.
Correct, ma'am. Ma'am, can you suggest some tips for HPV vaccination counseling?
Tips is again I keep on telling the same thing. Conviction. You have a conviction on your own. कि हाँ भाई ये मेरी जवाबदारी. It's my duty. It's my moral duty. Once person puts up themselves as a moral thing ना, आप देखो आप कहीं भी रहो आपके मुंह से HPV vaccination ही निकलते रहेगा. खड़े रहोगे.
As a cancer prevention vaccine, that's also very, very important.
Do not put it up as a STI. Let me please tell you this thing. क्योंकि आजकल जैसे Google era है, the people put an HPV, they understand it's something like, and they really get hesitation. Now, when I was called to NDTV में जो it was the stakeholder meeting and policymakers meeting, it was a very high profile meeting. इस meeting में there was one thing which I really appreciated was de-link HPV from STI. De-link it. That means there is no taboo related to HPV. And having an HPV today also, no, people really get so upset. They start having the question mark on promiscuity. These things have to be removed out of the brain. That there is a Canadian study which has said that even the naive, one-to-one relationship, naive, both the partners are naive, just for first timers. Even in them, 30% of people became positive in that university within a year, and 50% in within 3 years. That means now you can understand that HPV is not related like an HIV, like a multisexuality and all that. So this is something which we have to understand and put it across.
Almost everyone get infected with HPV in lifetime, at least 80% of us.
Okay. Yeah. Thank you, ma'am. One more question is, ma'am, how to recommend HPV vaccination?
Yeah, Ruby ji.
We should always have a positive recommendation, and we should always avail every opportunity that we recommend them vaccine for their daughters or granddaughters. Not that she will always come to us bringing her daughter. Suppose she brought her daughter to emergency. The girl had some trauma. So treat her. At the same time, Also, we can ask, oh, she's 10 years old, and have you heard of cancer prevention vaccine? This is the right time when she can take the vaccine. And if you have a menopausal clinic and a woman is 60 years old, so we can always ask how many granddaughters you have. And if you find that she has someone between 9 to 14 years, so do not miss the opportunity to counsel for HPV vaccination of that young girl. So we have to find the opportunities, and it should always be a positive recommendation, and which can make them accept the vaccine with confidence.
Thank you
So
so
I
much,
think
ma'am.
we have, thank you, Dr. Anupam. We have exceeding our time, but I would request Dr. Gunjan to ask her questions very quickly now. The last three are almost a repetition of what you said, but please go ahead, Dr. Gunjan, please.
Thank you, Dr. Sunila ma'am, for giving me the opportunity to interact with these stalwarts. My question to the panelist is, what is the effectiveness of the vaccine in the long run?
A very good question. This comes in mind of every parents and guardians, that the various scientific evidence till date, they show that it has a very long-term efficacy and no booster dose is required. So once she has taken 2 doses in 9 to 14 years, or 3 doses after 14 years, or the efficacy is long-term efficacy is 100%. And there's no decrease in the efficacy.
Okay, thank you, ma'am. Ma'am, my second question is this vaccine is safe for the girl?
Absolutely safe. Don't have to have any doubt about it. Apart from the local reactions that can happen with any injections, we don't have any long-term, this thing, and it is very safe. Now, when we talk about vaccine, the question comes is, so my child will never get a cancer also. There has been studies even to the end point of seeing precancerous conditions. Now, not only the cancer, it's also preventing precancer. Endpoint results become SIN3 plus or AIS plus, no, like that. So it's quite a safe vaccine, and there are not much of a side effects which has been mentioned or studied.
Okay. Okay, ma'am. As you know, in the India, affordability is a major concern. So the major question as frequently asked by the parent is, what is the cost of the vaccination? Different vaccination, and which one is the best to recommend?
Actually, ideally, see, cost, if we are getting our own serum vaccines, our own CERVAVAC. So CERVAVAC definitely is cost effective, and it is coming within the budget also. And we are going to give 2 vaccines, but CERVAVAC we can't give beyond 26 years. That's one thing we have to understand. So beyond 26 years, we do have only the licensing for Gardasil 4. Even Gardasil 9 is not licensed in our country for beyond 30 years, beyond 26 years.
26
So yeah, so that is where we understand that. And another thing you have to also mention that when you compare that with the cost of the cancer and all that thing, so vaccine ka to kahin bhi kuch is not that great. This thing.
Treating cancer, we need lakhs and lakhs.
Yeah.
And then also we do
So-
not know how much is the survival. So
How-
we cannot compare the cost of vaccine with the cost of treatment of the
Okay.
cancer.
Okay. मैम क्वेश्चन और जो पूछा जाता है कि कुछ लेडीज आती हैं कि हमारी सिस्टेक्टमी हो गई है एट द एज ऑफ 35, और तो क्या हम एलिजिबल हैं, क्या हमको लगवाना चाहिए वैक्सीनेशन, एचपीवी वैक्सीनेशन?
वैक्सीन इज फॉर एनल कैंसर्स भी सब कुछ आता है ना इसमें, वजाइनल, एनल, हारा, सब कुछ है. So hysterectomy, having a uterus is not the prerequisite for a vaccination. No?
Okay, ma'am. Okay.
Yeah.
Thank you so much. Thank you so much.
Thank you very much.
Thank you everybody. Thank you for the speaker. Thank you, Dr. Priya. Thank you, Dr. Preeti, Dr. Ruby, and our co-moderator, Dr. Sunila Soni, and all the panelists for a wonderful discussion on this very important topic. Because previously our only strategy for cancers was detection and treatment. But now we have a very, very important strategy for cancer prevention, and that is by vaccination. So this is one cancer which can be prevented by giving 2 shots of vaccines. For bivalent vaccine, it is only 4,000 rupees for 2 doses, and for quadrivalent, it is I think around 7,000 to 8,000, and for nonavalent, it is probably going to be around 18 to 20,000 rupees. But it is definitely not a cost which is very, very significant, because the cost of treatment of cancer and quality of life after cancer is definitely very, very high. So thank you everyone, and the message is very, very clear, and the message is very loud also, that we must recommend HPV vaccination for all the eligible population. That means the children of age 9 to 14, and we should also lobby ourselves to recommend the government that it should be included as soon as possible in UIP, so that we can basically cover all the population, and we can effectively reduce the incidence of cervical cancer and all the other 5 cancers which are preventable by HPV vaccination. Thank you everyone, and good night.
Thank you
very
Dr.
much.
Thank you
Jan,
and good
Very
night.
Dr. Sharminder, Dr. Pawan,
Thank
Dr.
you
Sunita.
everybody,
Thank you
and
very
good night.
much.
Good night.
Good night. Yeah.